We'll go ahead and get started with our second session for today. I want to introduce our speaker, Dr. Silvers. Dr. Silvers is the Medical Director of Infection Control and Pharmacy for Sutter Health, where he serves as the physician lead and expert on COVID-19 for the healthcare system. In his role, he works closely with the California Department of Public Health, where he serves on several advisory committees. He is also on the board of Infectious Disease Association of California, the Advisory Council for the California Immunization Coalition, and has spoken nationally on immunizations. I also want to add that Dr. Silvers has graciously done several COVID-19 webinars with us when the pandemic hit, both professionally and for patients. He's also helped review, I believe, one of our professional resources that we developed. So he's been very much integrated into the NCC and has really been a great support and help to us over these last, oh my gosh, 2.5, coming up on 3 years. So he's been a really good, partner with us and the NCC. So I'm going to go ahead and turn it over to him, please, as he's going through the presentation. Please, we want to hear from everybody. Put your questions and comments into the chat, and we'll have a few minutes at the end to ask Dr. Silvers some of those questions. So, Dr. Silvers?
Great. Thank you, Stephanie, and it's great seeing you again. And thanks for inviting me back. So today, the reason I'm showing this crow's nest here on the left is because I'm trying to give a high-level overview of flu and COVID and monkeypox and what you need to know. I'm going to give a presentation, a mixture of kind of what the average person on the street needs to know and some scientific information behind it. Next slide, please. So the first thing is kind of the obvious. You need to know the difference between COVID-19 and influenza. Next slide. So influenza, it's predominantly a seasonal contagious virus. It's a respiratory virus, and it leads to increased time off work or school, hospitalizations, and death. It has a lot of what we call morbidity, illness, and mortality, people dying. COVID is not seasonal, as you obviously know, as we've dealt with this for going towards 3 years, about 2 3/4 years now. And it has the same complications in terms of time off work, school, hospitalizations, and deaths, but also has long COVID and many other things that flu doesn't have. Flu is actually a frequently used shortened version word for the word influenza, but in lay language, sometimes people with diarrhea say that I have the stomach flu. And that's not really influenza. It's a different virus, but that's just common terminology people use. Next slide. Okay, so how are they different? So, influenza is mostly seasonal, usually in the winter, and COVID is not. COVID, they're both respiratory, but COVID just has a lot more complications involving multiple organs and clotting and strokes and heart disease and long-term residuals. Next slide. So what you need to know, there's 3 or 4 different strains of influenza that circulate every year, and they vary a little bit, and sometimes you could have more than one during a season, so you can get influenza more than one time during a season, just as you can get repeat infections of COVID. Importantly, we have vaccines for both influenza and COVID. You can reduce your risk, of course, by social distancing, wearing masks, good hand hygiene, and vaccinations are really important. Next slide. So let's go over influenza. Next slide, and talk about what's going on this year. So here's where I'll show you some science. So the Southern Hemisphere, their season for flu, their winter is during our summer. So when we look at their winter season, which again was during our summer, we can sometimes predict what we're going to see. So this shows influenza from October of 2017 up and through October 9th of this year. And the brownish color here represents influenza B, and these various shades of blue and teal represent influenza A. And what you can see here, these are the number of specimens per week. And so you can see this is a high point here in the 2019 season for them, which was during our summer of 2019. That's their winter. And then when COVID hit here, they really had no flu until this recent year. And their winter, our summer, they had the biggest outbreak they've had in well over 5 years. Most number of cases. It was shorter than these other outbreaks they typically see, but it was very intense. Their system was overwhelmed. It was almost all influenza A. Next slide. So that, of course, would suggest that we might have a big flu outbreak because they predicted. So where are we? So this is the Northern Hemisphere, which obviously includes Europe and Asia as well as North America. And if you look here, this is 50,000 specimens in a week, a much bigger number, much higher population. And this was the 2018 to 2019 a season. You can see it was mostly influenza A. This is the 2019 to 2020, which was a lot of B as well as A. All of a sudden, COVID appeared, influenza disappeared until our last season, which instead of being a single spike, had two phases to it. They had an early and a late season, with the late going into our summer, which is very unusual. But more importantly, here's where we are now compared to where we would be around this time normally. And we're just about the same place, except it's mostly influenza A. Next slide. So Eastern Asia, you look at sometimes, and you can see what they're doing. And here is their 2 season. And you know what? They're having a little bit more flu there. This is influenza A than we would normally see this time of year. Next slide. Now let's go to North America. And you can again see the spikes through the various seasons. COVID came along, and then last season we had 2 spikes, and here we are now. Not a lot of flu in the United States based on this World Health Organization series of charts. Next slide. Now, if you look at our data through the CDC, it looks like it's actually increasing in parts of the United States, especially the southeast and southern United States. California remains low. It's mostly influenza A, which is what I showed you, with just a little bit of B. And very importantly, a fourth of the isolates are influenza A H1N1. There's 2 types of influenza A. There's H3N2 and H1N1. Most of the world has only H3N2, but India has H1N1, and the United States has quite a bit of H1N1. Next slide. So this is a map of the United States, and this is actually not the most recent, but it's similar. It's just a little, there's more. And so the reddish colors means there's a lot of influenza. So you can see District of Columbia here in Georgia, Texas, and most other places. You got some yellows here for moderate, and go towards the northern part of the United States, mid-northern and northwest. There's really not much. And then California is just a little bit. And if you had the more recent map here, I turned this in before that one came out. There's actually more yellow in southern United States, the southeastern United States, and New York City is now red. So there's more flu in parts of the country, actually throughout the country. Next slide. And what you'll see here is, again, the number of cases are increasing. This is the amount that are positive. And it's just showing an uptick here. So we're starting to see more flu in the country. Next slide. Okay, so we are seeing more. Numbers are still small, but actually they are increasing. And the influenza A H3.2 is the main circulating strain, and the vaccines anticipate to have good coverage. So this is actually a hard one to match, but so far right now it's matching well, and that may be the most important strain. Next slide. Okay, so there's lots of options for the flu vaccine. Next slide. So people with kidney disease are at increased risk. Chronic kidney disease weakens your immune system. About 1,000 people a year die unnecessarily from influenza-like illness who have end-stage renal disease. And people obviously with kidney disease, as you know, have lots of other illnesses associated with them, frequently diabetes, heart disease, lung disease, of course, obesity, and they all increase the risk of more severe disease. So people with kidney disease have extra concerns about flu. We're starting to see more flu in the United States. It looks like it's going to be a good match for the vaccine. Next slide. So everyone 6 months or older should receive a flu vaccine, CDC guidance. There's some rare exceptions, but people at high risk of developing serious complications, chronic kidney disease, are especially important that they get vaccinated. Next slide. So everybody 6 months and older is recommended to get a standard dose of inactivated flu vaccine. That's a predominant vaccine. This is brand new. We have what are called enhanced dose. You've probably heard of the high dose vaccine. And this is the one that's high dose for 65 and older. There's actually two other types of flu vaccines that are considered equivalent, although the way they produce them is different. This is an adjuvant vaccine. It has something called squalene in it, which makes your immune response better. It doesn't have as much of the flu antigen, but it has enough. And when you add this adjuvant, the response is excellent. This is a recombinant vaccine called Flublok, which is not egg-based, and it's approved for everyone 18 years and older. So people with chronic kidney disease or diabetes really should consider, if you're 65 and older, you could get this. If you are 18 and older, you might want to consider this one, but any standard flu vaccine is approved for 6 months through 18, and then 65 and older, you must receive the enhanced as long as it's available. There's also the nasal influenza vaccine called FluMist. It used to be said that if you were between 2 and 49 years of age, really, that if you were, the only ones who could get it were people that were healthy and not pregnant. They've changed it now that people with kidney disease and diabetes, other things, can consider it. But you really need to talk to your doctor because there's a reasonable chance your response still won't be as good as with other vaccines. So it's a very situation-specific choice. Next slide. Okay, so what about the high dose versus the standard dose? And basically, this is a study over 5 years. And what it showed, that people were on dialysis for at least 9 months. And they compared them to getting either the standard dose or versus the high dose. In that case, that's all they were using that time, as the high dose versus all 3 enhanced vaccines. 250,000 people were enrolled, and over 500,000 seasons, because they looked over 5 years, where they were vaccinated. And most received the standard dose. Small percentage receives the high dose. And the next slide shows you that really they were the same. So that's why the CDC hasn't changed yet and said if you have chronic kidney disease, you should get the enhanced vaccine. Studies like this don't show that it has made all the difference in the people under the age of 65. Now, again, if you decide you want an enhanced vaccine and you're 18 and older, you can get the Flublok. Next slide. Okay, so that study I showed you has lots of limitations. It's hard to do good studies. In the back, next slide. Okay, so final conclusion, it's really uncertain whether the enhanced flu vaccine really provides benefit if you're under 65. Standard dose is a recommendation. I mentioned the Flublok. It turns out, I did some research after I put this in here, and for those that have Safeways, which is a fair amount in the country, I think, they offer the Flublok. Now, I didn't go all over looking for CVS and Walgreens and Costco, these other places, but it is available, and that's an option. I'm not here recommending it. Next slide. Okay, get your flu shot. Get your flu shot. If you're sick, make sure you isolate, wear a mask if you have to get dialysis, and physical distance, wash your hands, do all the proper things to protect yourself. Next slide. Myth versus facts. Next slide. Myth. Getting the flu isn't a big deal. Oh my, it is a big deal. I've seen a lot of people through the years who've died from influenza. I've seen pregnant women lose their baby, even the second and early third trimester near the end of pregnancy from influenza. It can be a big deal. Next slide. Okay, vaccine. I got vaccinated last year. I don't need it again. The virus mutates. It finds ways to get around our previous immunity. So yes, the vaccine for flu isn't perfect. It's based on what we're seeing circulating in Australia for deciding what we're going to get the next year. And you do need to get it every year. Next slide. So Voltaire said, perfect is the enemy of good. And this kind of goes back a little bit to not getting a perfect kidney, the same idea. Just because your kidney for transplantation wasn't perfect doesn't mean that you should accept it and take advantage of the possibility that it might really change your life. Just because a flu vaccine isn't perfect and doesn't always work doesn't mean that you should avoid it because it may work. It may protect you and your loved ones. You may not end up in the hospital because of it. So again, same concept. Next slide. Take home, this is kind of repetitive what I said. And the bottom line, the time to get the flu vaccine is now. Next slide. Okay, so let's move off of flu and go on to COVID. So you have to kind of one of the fundamental principles of infectious diseases is that the purpose of a virus is propagation. The purpose of an organism, animals, is propagation. It's to produce more. And when the virus kills the host, that doesn't help it propagate. So viruses keep mutating. And if the purpose of the virus is propagation, is get everybody sick over and over again, try not to kill everybody, so you can keep on as a virus surviving. Next slide. So what do we need for normalcy? I put this together about 2 years ago. I said, you know what? We need to have sustained infection prevention. People need to understand hand hygiene, when they need to mask, social distancing. We need to have treatments for people, oral treatments, and we need to have good vaccines. And guess what? We have all these now. Next slide. Epidemiology. So a lot of people talk about epidemiology, and just so you understand what the word means, it's a complicated definition, but basically we just look at the disease, where is it located, what causes it, and develop knowledge on how to prevent it and control it. Next slide. Okay, so you hear about COVID variants. There's two main groups of COVID variants. There's the ancestral strain, which started in China, and it goes through Delta, and then the Omicron, which is really a very different one. And everything we've been seeing now for a while has been Omicron and things off of Omicron. And we get all these variants and subvariants that are either off the ancestral strain or off of Omicron. And what's really important is immunity to one of these two groups is not very effective at preventing immunity to the second group. So if you're immune to the ancestral strain, you're still very susceptible to the Omicron strain. So we developed a vaccine now that provides antibodies to both the newer Omicron as well as the ancestral strain. Next slide. So Europe may foreshadow what we will see in the United States for COVID, just like Australia does for flu. And right now, there's a lot of increasing cases in Europe, fortunately not with hospitalizations. The people who are 65 and older, the cases amongst them are rising the most. And many of the European Union countries are seeing more cases. And most countries don't have the mitigation. They're not doing the social distancing. They're not doing the masking. And again, the booster uptake, which is so important. When this was printed, it was a couple weeks ago that this came out, uptakes are below expectations. Now, when you look at the charts below, what you'll notice here at the very end of each of the graphs is this uptick. It's going up again, it's going up again, it's going. That's just showing various parameters we're looking at. In this case, is France. And cases and hospitalizations, not as much, but cases and are going up regularly. Next slide. So this is CDC data, and what this looks at is the subvariants, the various variants that we see. And in the United States, and this goes through about 4 days ago, you can see this BA.5 here. That's the main thing that's circulating in the United States. This blue one above it is the BA4.6, what I've never thought was going to do much. And then above that are some other various colors that are all of a sudden starting to appear, the black and the red and the green and this yellow-green here. Those are the new ones that are coming along, that when you see how week to week, when you look at the vertical columns next to each other, some of those new colors are starting to get bigger. Those are the new ones that are threatening us now. Next slide. So we also look at county level trends to see whether we should require people to wear masks in restaurants or in schools or shopping. And so this looks at how much disease is in the counties. And red, of course, is bad, and yellow is medium, and green is pretty good. And you can see the end of July, there's a lot of red and yellow in the country. We're seeing a lot of COVID. Next slide. And this was October 13th, and you can see it's almost all green. And so this is really good. This tells us that it's okay that we've been decreasing requirements on people for masking and social distancing, never decrease hand hygiene. Next slide. Now, that's different than dialysis units, hospitals, nursing homes, where we look at something different. We look at not how much disease is there, but how many new cases are coming, how much is being transmitted. And in this case, red is a lot, and orange is substantial, yellow is moderate, and blue is low. So we're not looking for green. And you can see on this one here, which is the last week of data they have, there's a lot of red and yellow and orange in the country and not a lot of blue. So there's a lot of disease being transmitted, although the number of new cases, the number of cases being identified are not changing. There's still a lot of new cases coming along. Next slide. Now, at Sutter Health, we track our data here, and this is the first bump you see on the left is from what we call the Delta strain, and that was part of the ancestral strain. And then this middle bump here, where there was a lot of cases being positive, this was the Omicron. And then this wide hill over here on the right, that's the BA.5 that's been circulating the most. And then we follow on the very far right, I follow the trends to see when these new subvariants are going to occur. This is see the next slide. And then I separate it by various parts of Northern California emergency departments. And you can see that if you go on the right bump, you can see the downslope of the orange and the blue, which are symptomatic people in emergency departments in different regions of Northern California in the Sutter area. And the yellow and the black are the asymptomatics. They're very similar. Now, if somebody wants to think, well, what about all the home testing? Does that get into any of this data? The answer is no. Next slide. Okay, we've redefined up to date on vaccinations. Next slide. So a primary series plus receipt of the most recent booster dose recommended for you by the CDC is considered up to date. So I had multiple boosters after my primary series, and it wasn't until I got my bivalent booster that I now became up to date again. 6 months to 4 years old, we still only have the primary series. 5 years and older, a dose of bivalent booster after the primary series. That'd be either Moderna or Pfizer. And people are moderately, severely immunocompromised. The primary series may be 3 doses instead of 2, but it's still 1 booster. It's the bivalent booster, and it's 2 months after either you complete the primary series or received your last booster, whichever was the most recent. Next slide. Okay, so Pfizer put out their human data on the bivalent booster, and what they showed, this is some of the first data coming out, is that side effects are about the same as previous boosters, which is good. Not great because people still get knocked out. Some people do from their boosters. I've been very lucky. My wife's been lucky. My daughter, she was down for a day and then she was back. It also showed that this bivalent booster has activity against BA.4.5, which have been the main things we've been seeing. And it's thought to be good enough in all age groups. And the Moderna data actually is out now, and that'll be about the same. So the BA.4.5 is where the new subvariants that you're hearing in the news today are coming from. So the bivalent booster provides antibodies against this, with the goal to also protect against the new ones that are going to come off of these. Next slide. Okay, this kind of is a recap, and influenza bivalent COVID booster vaccine uptake is uncertain. And you know what? It's really important that people get vaccinated. Now, when I put this together and submitted about a week ago, the numbers were of uptake were worrisome. I can tell you, and I was on a meeting early this morning at Sutter, And I know where we are locally in Northern California, the number of people going for their boosters and their flu shots is increasing dramatically, which is really wonderful. And if you haven't had either or both, you really should get both. And you get them both the same day, and that's absolutely fine. I know a lot of people that have done that. You don't have to, but you definitely should get both. And you may not be able to find an appointment the same day, and walk-ins are harder depending where you live, but don't give up. Next slide. Okay, let's go through monkeypox a little bit. Next slide. So we share organisms with animals and wildlife, and they all share back and forth now. Now, that's partially because we're encroaching the domain of the wildlife. We want to live where they live, and then we have domestic animals, and everybody's sharing back and forth. We're altering the habitat where wildlife lives, and therefore they're encroaching our domain. We've intensified agriculture and animal husbandry, and then, of course, global travel, human manipulation. There's all kinds of reasons why we're all sharing organisms between each other. Next slide. So this is the situation updated about a week ago. And globally, there were about 72,000 cases in non-endemic countries. That means those are the countries that did not have monkeypox before this outbreak. And notice the death rate is happily very low. So when there's two strains of the monkeypox in Africa. There's the Central African Congo version, which has probably a 10 to 25% mortality. And then there's closer probably to 10. And then there's the West African strain, which is what we're seeing, which has had about a 1% mortality prediction. So if we had 1% die from monkeypox since this outbreak occurred outside of the endemic location, we would have had about 700 plus deaths. We've only had 15 in the world, which is wonderful. I believe it's up to 20 now, but it's still a small number. It's rated about 1 in every 5,000 people who get monkeypox. Cases in the United States, of course, are 27,000 for men. It's a little higher now, but California, New York, Florida, and Texas having the most. I'm located in California, and so I follow our data. And as we're seeing across the country, it's almost all male. About 3/4 are in the 25 to 44-year age group. Very few pediatric cases, and that's exposures to some of them are adolescents, so that puts them kind of at risk, and some of them are the very young who has a family member, a relative, or somebody who comes in who has monkeypox. And limited hospitalizations, running about 1 in 20 people who develop monkeypox get hospitalized. Next slide. So this shows the world numbers. This is the daily confirmed cases. And you can see here that we rapidly had an ascent, and then it's rapidly come down, and will hopefully continue to decrease, which it probably will. Next slide. This is the United States graph, and you again can see that it peaked and it's coming down. It's not coming down as fast as it went up, but that's okay. It's continuing to decrease. Next slide. So why are cases decreasing? Well, there's multiple different reasons. Number one is most of the disease has been in MSM, men who have sex with men. And they took a survey, and after monkeypox cases and the outbreak was being identified, CDC looked at a survey that showed the high-risk population, 50% approximately, were changing their behavior so that they didn't have to put themselves at risk, which is great. Then Pride Month, you think that the peak probably occurred during Pride Month, where there was probably increased encounter risks. And since that month is over, the numbers are going down. I think that's part of it. Next slide. Then vaccination. We have vaccinations for pre-exposure and for post-exposure. And it turns out, even though it's a 2-dose vaccine, there's data now that the first dose really provides significant protection. Second is better. And then fourth, they're doing contact tracing. So when they find a person who has monkeypox, they're tracking the contacts of that person. They're vaccinating the contacts of that person and the contacts of the contacts. That's called 2 rings. And then limited transmission. Happily, this is nothing like COVID. requires sustained close contact. It's not aerosolized much, and once you get it, it's extremely unlikely that you'll ever get it again. Same thing like smallpox, which is related to. Next slide. So we have post-exposure prophylaxis. So these are people who, I'll go through it. This is enhanced post-exposure prophylaxis and pre-exposure prophylaxis, 3 categories: PEP, PEP++, and PrEP. So PEP is for people who within the last 4 days have been had a significant exposure to a person who either is suspected or is known to have monkeypox. They have other limited definitions for healthcare workers because the actual risk is pretty low, happily. And then PEP++ is enhanced PEP, and that's for people who have activities or social behaviors that put them at risk, but they don't actually know whether they were exposed to anybody who had monkeypox. And so that's the same idea. And then PrEP is people who haven't had an exposure, but they may engage in activities where they could have an exposure and they want to receive it. And then this is also for lab people who actually perform the testing for monkeypox, but not actually the collection of specimens, and research personnel who actually handle cultures or contaminated infected materials. Those are both very small groups of people. And then for healthcare workers and dialysis workers, this basically clinicians, healthcare workers are not advised to receive the monkeypox vaccine at this time because the risk of actually acquiring the disease is very little from work. Next slide. Okay, so what about monkeypox in healthcare workers? Well, first of all, the vaccine supply is adequate for all 3 categories. It turns out that likelihood of acquiring monkeypox through patient exposure is very low. There's data supporting that, which is wonderful. Vaccination, therefore, should be given after a high-risk exposure. So if you have a known exposure as a healthcare worker, you might get vaccinated at that time. Go for it. It makes total sense. But vaccinating large population of healthcare workers doesn't. And the other thing is this goes back to something I talked about earlier, which we call personal protective equipment, PPE. It's hand hygiene, it's wearing appropriate gloves or mask or gown in appropriate situations, it's social distancing for COVID and flu, but not so much for monkeypox. And of course, general PPE for monkeypox, if a dialysis patient has disease, for example, the dialysis worker would be wearing a gown, gloves, an N95 respirator, and eye protection. Next slide. So, conclusions here. We have multiple commercial labs for testing for monkeypox, readily available. Turnaround time is usually about 3 calendar days. Tecovirimat is a treatment for monkeypox. It's very well tolerated. We don't have data yet whether it actually shortens the course of the disease. And then there's 3 categories of people where vaccination makes sense. Cases are decreasing throughout the world because of education, decreased risk-taking, vaccination, contact tracing. If we stay the course, this outbreak can be controlled. Now, the CDC has written, and I agree, they're anticipating that monkeypox is not going to go away and that it will probably stay at low levels within the high-risk MSM population, but there will probably be a very limited transmission outside that population, and individuals who are in that population can and should get vaccinated. Next slide. I have time for questions.
Thank you, Dr. Silvers. As usual, really a great presentation, a lot of good information. And we do have some questions that came in through the chat, so we can get into those. And please, anybody else, please continue to send any questions for Dr. Silvers. We still have plenty of time here. So the first kind of question was regarding your slide 39. She asked, explain what unnecessary deaths are.
Unnecessary deaths are people that have died from complications of of influenza and they were not vaccinated. In that particular that particular study, that's how they were defined.
Right.
So that has its limitations like every other study does, right? Yes.
Right. Another question, what makes the vaccine for over 65-year-olds enhanced?
So there's three different ones. First is the high dose. And the high dose has first of all, there's four flu strains in each vaccine, right? And the high dose has 4 times as much of each of those four strains. So it's a lot more of the stimulus to your body for the body to recognize that it needs to make antibodies. The adjuvant vaccine has the standard amount, which is 15 micrograms of each, versus the high dose, which is 60, but it has something called squalene in it, which stimulates your immune system to make the antibodies, and the squalene is right next to the antigen, which then your body says, oh, this is what I need to attack. The third one is it actually has an intermediate dose. Instead of 60 micrograms, it has 3 times the normal dose, so it's 45. And because of the methodology of it being produced without eggs, it gets the same immune response as the high dose.
Right. Another question here. As a healthcare provider, what advice do you have to give to patients who are asking, or saying, I have received the 2 initial vaccines and a booster. Why do I need to get any additional vaccines for the COVID-19?
So what I tried to explain, and of course I went through a lot of data, is we have the ancestral strain and we have the Omicron strain, and those are both big ones. The ancestral strain started with Wuhan, and then we got an alpha, a beta, and a gamma, and a delta, a bunch of them off of that, but they're all related. The Omicron is really unrelated to, it's very different than the ancestral strain and everything that came off of it. And then we have all the newer ones that are off of the Omicron. When you got your earlier vaccines before the new bivalent one, you did not get adequate protection against the newer Omicron. And that's because the antibodies that are developed necessary for Omicron are different than the original Wuhan strain, the ancestral strain. So you need both now.
And kind of sort of a follow-up to that, do you feel like the COVID-19 vaccine will become an annual vaccine, much like the flus every year?
Yes, I anticipate that. And that's kind of my hope. So they're already working on a combination flu COVID vaccine, which I'm hopeful that will be available next year. I'm sure they will still offer separate ones for those who want to receive them separately. But we're not going to be able to consistently get the population to take vaccines against COVID 2, 3, 4, 5 times a year. So that's unrealistic to have a long-term plan. And so I think they're going to be one. There's some interesting data just came out that people who received the Pfizer or the Moderna vaccines and booster, they actually, they're healthcare workers. They weren't as ill as unvaccinated. They weren't out of work as long. They didn't have fever as long as people who were unvaccinated. So, I mean, is it a perfect vaccine? No. Don't, I'm not even going to begin to say that it's anything close to perfect, but it's better than none.
Good. Another kind of question, transplanted patients are not allowed the flu mist, the live virus. Is that correct?
Yes, that is correct.
So,
Whereas a dialysis patient would be, but would be if they're 49 years of age or less. Whether or not it's the way you should go, well, you can discuss it with your doctor. It may or may not really work as well, and probably doesn't work as well in a chronic kidney disease person as the other vaccines do.
Okay. Well, let's see. If someone wants to get both, and I'm sure she's replying to COVID and flu, but not on the same day, which should that person get first?
Well, that's kind of, a little bit of a tossing a coin right now, because actually flu and COVID are both on the incline, unfortunately. And you can space them out, not very far apart if you don't. I mean, you don't have to space them weeks apart. And I can't say. I guess what I would say is if you are in the southeast, part of the United States, where there's a lot more flu right now, I'd probably get the flu shot first. If you were in California or Arizona or Washington, I'd say I'd probably get the COVID one, but it wouldn't matter. Your choice.
Right. Okay, we've got, here's another question. Monkeypox affecting primary males. Do we know why?
Because it's the mode of transmission. It's close skin-to-skin contact, and it's not just touch something for a second and you get it. It doesn't have the airborne risk like the other viral infections we've been talking about, like flu and COVID. So it's really close skin-to-skin contact for a significant period of time. So it's usually sexually transmitted. In terms of sexual, they don't call it a sexually transmitted disease. It really is a sexually transmitted disease. And I don't know whether it's politics that's preventing them from saying that, but that's fine. And that's why it's mostly in that population. The really young kids have gotten it, have been with a household member. They're usually, like under a couple, up to maybe 3 or 4 years of age, and a lot more clingy. And so the skin-to-skin contact is harder to prevent.
Sure, makes sense. Yeah. Okay, we've got one here. It said, I think clarification here, Dr. Silvers. Did you say that ancestral COVID vaccines are not effective against Omicron strains? Are next generation vaccines available that are specific to the Omicron?
Okay, so the ancestral strain is not as effective, which is different than not effective. The new bivalent booster, which is the only booster permitted now for any, I'm sorry, the Novavax just came out today. Okay, up until today, that was the only booster available for people 5 years and older. And it has, think of it like a Y, even though it doesn't look like a Y. So the stem of the Y is kind of this, first of all, the spike protein is a part of the virus that these vaccines are designed to form antibodies to. Now you can pretend that this vaccine is a spike protein that's Y-shaped, and the stem of that is the part of the S protein that doesn't bind to our cells, but it gives us stability. Then one of the arms of the Y will be the ancestral strain, and the other arm will be the Omicron-related strain. So then your body sees two different things that it needs to form antibodies to. And that's where the new vaccine is. Now, just today, or maybe it was yesterday, but I just heard about today, the Novavax, which is a different formulation of a COVID vaccine, is approved for a booster for 18 and older. It does not have anything special for Omicron. So it's approved, but my personal recommendation would be to not choose that with things the way they are.
Okay. Another question here regarding COVID. Is it possible to have your antibodies checked specific to the ancestral and the Omicron strains?
No. And antibody titers are, we don't really know how to interpret the antibody titers because, right now the spike protein is probably the most important of the antibody titers, but it's really specific parts of the spike protein that are the most protective. And so we measure kind of all of the spike protein antibodies. We can't separate the ancestral from the Omicron strains, and we can't even tell whether they're good antibodies or not.
I think question here came in. It's asking about the flu forms, and I think you were talking about the myth versus reality. She was asking if they're available on our website because they're always looking for new materials. Where were those forms from, Dr. Silvers? Were those resources that you shared?
You mean the slides that I presented?
The myths and
Oh, I put those together.
Okay.
And you're welcome to take them and use them.
Jerome, are you on?
Yep. I will grab them and be able to share them out.
Yeah, I was going to say I believe we have some for patients, myths versus facts, similar to that. So
yeah, and I put a link as well to the NCC resources in the chat.
Okay, perfect. Yeah, and I put in the toolkit there. That didn't have that in there, but it did have a lot of other resources and information that anybody can go and use that and access. So
yeah, I think the only slides that I don't want you to use are the ones showing the Sutter Health graphs of our positivity rates, even though it doesn't really give you any useful information. Every other slide though is fine.
Okay. So let's see, is there any other questions? I'm just making sure we've got maybe just maybe 2 or 3 more minutes.
Yep. Stephanie, I see one. Will we have to get the COVID vaccine yearly like we get the flu vaccine?
Yeah, I answered that, but anticipate the answer to be yes.
Okay. And
yeah, make sure I didn't see anything. Donald put in there, Donald, I'm not sure what you're asking, natural immunity versus a vaccine, which is not sure if that's really a question. Are you referring to?
Yeah, it is a question then. People who have had COVID and have received the vaccine actually have better immunity than people who have not had COVID and just have had the vaccine. And of course, it depends what strain of the virus you had and when you had it, because that makes different antibodies. And so some people have said, well, I may as well just get COVID and get it over with and have my vaccine also. The problem that I have with that is long COVID. And long COVID is really, really debilitating. I'm still waiting to see data to show whether the vaccine can prevent long COVID or really cut down the risk of long COVID. And to me, that will be one of the biggest selling points of the vaccine for a population that would not be considered otherwise at risk. Obviously, kidney disease patients are considered high risk anyhow. But that is a big thing for me is long COVID. I've seen some very, very affected, previously healthy young people whose lives have been altered for quite a few months now by long COVID. And the reports are already, up to a couple of years of people whose lives have been totally changed.
Yeah.
Flu doesn't do that.
Just really one comment that from Ann, she just said that many people are getting the flu and COVID boosters at the same time, and I agree. I think there's been a lot of kind of endorsement of that and pushing to get that. If you're going to get it, might as well get them both, and you can safely get them both at the same
time. I think it's a great way to do it.
Exactly.
The only reason, the reason I did not is because at the hospital they were giving the flu vaccine and they weren't giving the COVID vaccine that day, although we wished they were. So I ended up separating them, but if they had been offered the same day, I would have done it.
Yeah, great. Well, I think, Jerome, can you go to the next slide, which I think is our CEUs? Again, I dropped the link in there too for everybody, or you can scan with your smartphone the QR codes for, remember, if you're a new user to the learning management system with the NCC, or if you're an existing, there's one code for each, as well as there's one link for each. Please make sure you scan the correct code. And I just want to thank you again, Dr. Silvers, once again to, take up on our challenge and our offer as a gracious person you are to always come and help us and present on our for the NCC and different webinars and meetings like this. We really appreciate that. And again, taking time to be with us today. We really really are thankful. And thank you for your presentation and all the good information that you provided. We really
Thanks for
appreciate it.
having me. Everybody stay safe. Have a wonderful
thank
holiday
you.
season. It's coming up soon.
Yes, yes. Yeah, thank you, everybody.